A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. We start with the name of Allah subhanahu wa ta'ala with the recitation of Nishan, which is the tradition of Australian Islamic Medical Association's all programs. So I invite Brother Ali Kashif to start the recitation. Brother Ali Kashif is, mashallah, a registered nurse in Nepean Hospital. Brother Ali Kashif.
Jazakallah khair. Assalamu alaikum, everyone. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. وهو الذي أنشأ لكم السمع والأبصار والأفئدة قليلا ما تشكرون. وهو الذي ذرأكم في الأرض وإليه تحشرون. وهو الذي يحيي ويميت وله اختلاف الليل والنهار أفلا تعقلون. بل قالوا مثل ما قال الأولون. قالوا وإذا متنا وكنا ترابا وعظاما أئنا لمبعوثون. لقد وعدنا نحن وآباؤنا هذا من قبل إن هذا إلا أساطير الأولين. قل لمن الأرض ومن فيها إن كنتم تعلمون. سيقولون لله. قل أفلا تذكرون. قل من رب السماوات السبع ورب العرش العظيم. سيقولون لله. قل أفلا تتقون. قل من بيده ملكوت كل شيء وهو يجير ولا يجار عليه إن كنتم تعلمون. سيقولون لله. قل فأنا تسحرون. صدق الله العظيم. جزاكم الله خير.
Jazakumullah khair, Brother Ali Kashif, for your melodious recitation. Ladies and gentlemen, brothers and sisters, I welcome you all today in Australian Islamic Medical Association's program. It's a great honor and privilege for us to have Professor Shafi Ahmed joining us soon, inshallah, from UK. Professor Shafi Ahmed is a leading surgeon. Alhamdulillah, his contributions and his services for the professions got a long list, and he is pride for all of us. Today's moderator for this program is Sister Zina Marhi. Sister Zina, alhamdulillah, has again a very impressive CV. Sister Zina finished her Bachelor in Science from Lebanon in 1997 and moved to Australia. Then she finished her Bachelor of Allied Health from Sydney University and worked as an occupational therapist in public and private sector. She went on to finish her medicine, Bachelor of Medicine and Surgery at the University of Sydney. And then she did a Master's of Reproductive Medicine from UNSW. She worked as a senior obstetric and gynecology registrar in Western Sydney hospitals. Currently, she is working as a CMO at Wagga Wagga Base Hospital. She is also working as an associate lecturer in UNSW School of Medicine. Sister Zina has a special passion, alhamdulillah, for community work and for relief work. She has worked with US Relief and conducted multiple medical missions to Cambodia, providing both clinical and surgical services to the disadvantaged communities. Sister Zina has a special interest in rural obstetrics and gynecology and improving access to health services in rural areas. In addition to medicine, Sister Zina has been heavily involved in community and charity work, both nationally and internationally. Sister Zina is moderator of today's program, so I will hand over mic to Sister Zina now to continue. Whether we continue or we take a few minutes break.
No, please continue.
Yeah, Sister Zina,
Professor Ahmed has just joined, so yes, please continue.
Sister Zina, over to you, please.
Thank you, Dr. Afzal. Thank you for the introduction. Assalamu alaikum wa rahmatullahi wa barakatuh to all our professors, doctors, brothers and sisters from Australia and abroad. I welcome you all for a very special event today with one of our prominent professors, Professor Shafi, as our guest speaker. I will be your host for tonight, so some housekeeping, please. If I kindly can ask everyone who joined to mute their mics, and also for the questions directed to Prof. Shafi, can we please use the chat box? Let me now introduce you to brother and Dr. Saleh. Dr. Saleh Khawaja is one of our members in Australian Islamic Medical Association. He graduated from the Peninsula College of Medicine and Dentistry in the UK in Exeter. He underwent his initial training in the UK prior to moving to Australia in 2018. He is currently training in emergency medicine in the Australian capital, Canberra. He has a very special interest in public health, and he is a very active member of AIMA, promoting public health and coaching basic life-saving skills. Dr. Saleh will be giving us a brief introduction about the Australian Islamic Medical Association. Please welcome with me, Dr. Saleh. The mic is yours, Dr. Saleh.
Jazakallah khair, Sister Zaina. Thank you for the introduction. Assalamu alaikum wa rahmatullahi wa barakatuhu, all brothers and sisters who have joined. It's an honor and a privilege to speak with you. Obviously, the topic of discussion today is about digital transformation. What many of us, I'm sure, have seen in one form or another to be the next steps in advancing effective collaboration in healthcare. Hence, IMA, in particular, the Australian Islamic Medical Association, were very willing to help put this program out to look at an example of what this could be. In terms of Australian Islamic Medical Association, a brief introduction. IMA was based and founded on the principles to connect our Muslim medical professionals, which included doctors, nurses, dentists, and allied health professionals, with the fundamental goals of uniting our brothers and sisters in the primary aim to help serve humanity. We have a team covering a wide breadth of the medical sphere: physicians, surgeons, general practice, emergency, psychiatric, and allied health professionals, as mentioned. Alhamdulillah, we have members from all backgrounds And we are a national organization now with a footstep in every state and territory in Australia, with members as well in New Zealand. Our work is centered around serving our communities, both locally and abroad, and promoting the principal values of Islamic-based lifestyle and healthcare. One of our main goals is to promote and facilitate research, education, and we think that this event is an ideal platform to showcase that. We have been recognized in our projects by the Australian Research Council as an Australian champion. If anyone has any questions about IMA or wish to know anything further about us, about who we are, what we do, please feel free to visit our website and maybe become part of our team. Jazakallah again, Sister Zaina, and thank you everyone for allowing me to have these few moments to speak. Alaikum assalam.
Thank you, Dr. Salah, for a very good introduction for our organization. I'm very honored today to also introduce one of our prominent general practitioners in Western Sydney, Dr. Naeem Islam. Dr. Naeem Islam doesn't really like us to talk much about his medicine career. He just likes to call himself as humble GP. However, Dr. Naeem is involved in various charitable organizations, both locally and abroad. He's currently the chairman of Charity Right Australia. He is passionate about reaching out for the most vulnerable in our community, the poor, the needy, the orphan, and the refugees. His main goal is to provide sustainable food resources and continuing education to those much in need. Welcome, Dr. Naeem. And can you please introduce to us Dr. Shafi? Dr. Naeem?
Yeah, Assalamu alaikum wa rahmatullahi wa barakatuh, my dear brothers, sisters, and esteemed colleagues. And to Professor Shafi Ahmed, we are from the same background. Assalamu alaikum, Professor Shafi bhai, how are you? আমাকে বলা হয়েছে আপনাকে যেন আমি বাংলাতে প্রথমে ওয়েলকাম করি যাতে একটু আপনি একটু ভালো বোধ করেন যে কিছু বাঙালি ডাউন আন্ডারেও আছে তো ইনশাআল্লাহ it is my actually to all of my brothers and sisters, I actually welcome our dear Professor Shafi Ahmed in our own mother tongue. And so it's a great delight and honor for me to present one of the distinguished professionals who had dedicated his life to science and helping others. Professor Shafi Ahmed studied medicine at King's College Hospital School of Medicine. As the elected president of the Medical and Dental Society during his surgical training in London, he undertook research at the Royal London Hospital and Queen Mary University of London. In 2010, he obtained a PhD. He has been awarded 4 honorary PhDs from various international universities. He is working as a consultant colorectal surgeon and professor at the Royal London Hospital. He teaches innovation and digital transformation for surgeons at Harvard Medical School and Imperial College London. While it's hard to mention all of Professor Shafi's achievements, I will take you through some of the highlights of his exciting career. Future Nhs Award, it is given by the UK Members of Parliament. In 2018, he was the award winner, and this award seeks to highlight individuals, teams, and organizations that are successfully embracing the opportunities from advances in medical technology, data, and connectivity. He also is the winner of Silver Scalpel as the best national trainer in surgery in 2015 by the Associations of Surgeons in Training, ASIT. World's most watched surgeon streamed live operations using Google Glass, virtual reality, social media, or on national television on Operation Live, which was shortlisted for a BAFTA award in 2019. He is the Associated Editor, Technology and Innovation at the Annals of Royal College of Surgeons. Member, Editorial, Strategic Advisory Board for BMJ, the esteemed journal we all know about, BMJ's Innovations. Professor Shafi is TEDx an international speaker, delivered over 250 keynotes in over 30 countries on innovation, the future of healthcare, and digital transformation. Featured in over 400 newspapers, technical journals, and mainstream TV news channels, including Sky TV, BBC, ITV, BBC World, CNN, ABC, Al Jazeera, RT, China TV, CNBC, Forbes, Bloomberg, Time, Wired, Guardian, and the Times. And these are just a few aspects of our guest tonight. It's really been an honor to introduce such an illustrious person at his young age, who has become really a spotlight, sir, and for our future generations. Dear brothers and sisters and my colleagues, without any further delay, I present to you Professor Shafi Ahmed, who will talk to us tonight about the digital transformation of health. Here you are. Thank you very much. Jazakallah khair.
Assalamu alaikum, everybody, and what a pleasure to be here. Thank you so much for the kind introduction. Its name, I'm Balasi. So that's just my getting back with our mother tongue, of course. So look, thank you so much for the invitation, and really good to meet all of you, really, and to really see what other people are doing around the world. Australia isn't too far away. We're a small world now, of course, connected by various means. Although COVID has been difficult for all of us, hopefully, inshallah, we'll get a chance to see each other fairly soon and travel all over again. So look, thank you for the introduction. I'm going to spend the next hour and a half, 40 minutes talking to you about my thoughts around the future of healthcare and what that might hold for all of us in terms of different disciplines, the technologies that will power healthcare in the next 10, 15, 20 years or throughout our lifetime. So let me just share my screen, and then hopefully it's going to be working. Can you just enable my screen sharing, please? Thank you.
Dr. Kalun, you have to make him co-host, I think, for him to enable share screen. You mute.
Yeah, thank you.
Yes, I'll do that.
Okay, hopefully you can see that screen. Just say yes if you can.
Yes.
Yes.
Thank you, Dr. Habib. Great to see you, Dr. Habib. Thanks for reaching out on LinkedIn.
Thank you.
Apologies, I'm late. We obviously had that miscommunication about the timings, but nonetheless, we're here. So good evening and good morning to people, of course, in the UK. So look, the future is going to be incredible. There's no question. We're living through amazing times. And I think COVID has accelerated our understanding of digital technologies and the way we brought them in at pace, changing the regulations, the framework, the technologies that underpin some of these new ways of working. So we're all now in a different place than we were, say, even 18 months ago. The first thing is to talk about where we are in the world. If we go back to about 6 years or so at the World Economic Forum, Klaus Schwab, the chairman of the WEF, came out with a statement and called it the world that we're living in is the part of the fourth industrial revolution, where computing power and exponential technologies were going to underpin our future. He talked about the blurring of the physical, digital, and biological spheres all coming together. What we're looking at now is, where we are now is an inflection point for humanity. We're seeing amazing technologies that weren't available even 5 or 10 years ago, suddenly becoming more pronounced and becoming available at the same point of human existence. When they talk about immersive technologies, artificial intelligence, nanobiotechnology, the underpinning of computing power with quantum computing and connectivity with mobile 5G, 3D printing, wearables, nanotech, genomics, Internet of Things or Internet of Medical Things, and of course this whole concept of big data. We've never had the riches that we have at the moment. And so this is the opportunity for all of us to think how we redesign that healthcare of the future and how these work together almost, not in isolation. The other thing I do is I do a lot of work globally. And I spent the last 5 years traveling to about 35 countries, working with governments, colleges, institutions to talk about how they may think about scaling up some of these ideas and to prove the outcomes for the patients and also to improve medical education. If you look at the World Health Report for 2030, this was back in 2015, of course, and it suggested that we were going to be short by about 50 million health workers across the world. We're seeing that now. People are leaving the profession. We're seeing changes in the way the workforce has been developing. So we're going to have a huge problem and burden for healthcare by 2030. my own profession of surgery as a colorectal surgeon and a cancer surgeon, we've seen the kind of the frailties of a surgical system around the world. The Lancet Commission 2015 predicted that about 2/3 of the population, so 5 billion people around the world, could not access what they called safe and affordable surgeries, simple operations that will improve morbidity and, of course, mortality. And we've seen, of course, during the pandemic, the inequalities of health compared to other parts of the world where many operations might be performed and how the COVID decimated surgical services. So that means we've got to think differently about the future. The WHO, of course, has now put out some recommendations around digital health interventions. And this was a few years ago, and I'm sure more will come out on how we contextualize some of these technologies to improve healthcare in various parts of the world. And this is in line with the UN SDG 3, of course, which is promoting health equality around the world. So we've got an ambition going forward. If you look at the governments themselves, they're now grappling with this future. This is our own NHS talking about various items around the future of the workforce, the TOPA review. We're looking at how we improve access, and there's many reports coming out now defining what that role might look at. And I worked with the RCS and I was a council member for 5 years on the Future of Surgery program. So that's really kind of the concept of where we are and what the global ambition is going to be. The first thing, of course, is to create the new digital healthcare person of the future. At the moment, of course, we've got more interest, people understanding what these technologies might mean, but have we produced the workforce that's relevant? So how do we create this digital doctor that needs to be relevant for modern society? And I think we've found so far with the medical school curriculum being archaic and really not supportive of change. We've seen postgrad training also rather slow in adopting new ideas. We're traditional by our very means. And surgery, of course, has always been traditional and not being changing quickly enough. Let's go back to UK, an example of what we're doing. I've introduced Bart Sex Medicine. I was Associate Dean at the medical school for 10 years, and we've brought in innovation, entrepreneurship, and technology into the curriculum, as also I've done Imperial and other universities. This is using these ideas to bring the entrepreneur of tomorrow into the undergraduate curriculum, who can understand the language of innovation and digital health. And of course, we're also seeing the accelerators, the innovators, the kind of incubators, and it's digital training, postgrad trainees, and the academies, of course, and the entrepreneurship program. We're putting together a system where it's more acceptable to think outside the box and to be the innovator of tomorrow. So the first question, of course, is what does that look like? What are we heading towards? And of course, we know the future of healthcare is going to be digital. There's no question. It's going to be connected. We are more connected than ever before. Of course, we talk about personalized care, which is driven by data, and big data is going to be a big thing. It's going to be a key parameter of how we understand the data, collect the data, and then, of course, implement change. Healthcare is getting more integrated with a seamless approach from primary, secondary care, so that we now will understand better the flow of patients through a system. And that includes social care, of course, which is a predeterminant of healthcare. And of course, we know how we work together, and this whole multidisciplinary team is going to evolve much more. So the other thing I do, I work with Vodafone, our telco provider, as their connected health ambassador for the UK. And we're actually going to launch the Centre of Health next week. And I do a lot of work with industry partners. This is our concept of the future hospital. It's going to be smaller. It doesn't have to be big. We have to keep thinking bigger and bigger hospitals. Actually, we want to keep people away from hospitals and into the community where it's much safer. It's going to be more connected, accessing records all the time, smart cameras, security. It's going to have connected ambulances, smart parking, asset tracking throughout the system. So the whole thing is more digitalized, so that the experience for people is going to improve. And of course, talk about experience, the UI and the UX, the user interface user experience, has never been talked about in medicine. And actually what we're looking now is how we create something that's more interactive, with more space, with better way of flowing through the hospital. We've seen the outpatients change during the pandemic, less outpatient face-to-face appointments, more virtual. So we have to adopt different ways of working, allow people to access healthcare in a way that's safe, smart, and more efficient. And that's going to be a key part. But of course, what's really going to happen is care is going to the community. We want people to stay at home. During the pandemic, we've seen patients with diabetes or COPD, for example, being treated at home. They don't need to be in hospital. They might use remote monitors, for example, for diabetic and their sugar levels, or indeed COPD patients with their peak flows. We're going to have obviously connected devices so that we can connect on the virtual platforms, tracking them, of course, and to ensure patient safety even at home, with care at the home. So this is the direction of flow, a connected, integrated system that's going to be much more seamless and driven by hard data. If we look at patient experience, I mentioned the UX that we use in computing language. We know that the emphasis has to be prevention and lifestyle changes to prevent the outcomes that are worse, prevent admissions to hospital. We've seen total triage take off and telehealth. And within a few months of the pandemic, we saw telehealth was up by about 8,000%. That's dropped down now. Now we're back to face-to-face, but there has to be a hybrid model. We're seeing how chronic diseases change. Remember, in the NHS, the budget of 100 billion, 60% of that budget is treating patients with chronic disease. So we can do better, we can save money, and we can use that same money more smartly. That's going to be the key. There's no more money for healthcare. Actually, it's asked for us to work out how we use that money more smartly and more efficiently. Care's been more personalized. Of course, we'll talk about remote monitoring. If we go back a few years, talk about where we were. This is the futurist of 1924. Talk about the radio doctor or diagnosis through a kind of mirror. But what they're talking about, of course, is telemedicine. 100 years before we really embraced it. We didn't really embrace it until the pandemic because we were forced to change. We're seeing now the rise of these visits across the world, lots of companies offering virtual visits that we all know about. Take it to the other extreme, we go to China and Ping An insurance company, for example. They have a telemedicine platform, which is used by 300 million active users. Can you imagine? Scaling, using that technology to scale at the very limits of a population health. Population health is important. Large populations now migrate towards cities. How to ensure that the rural communities are also well served in this manner. Of course, if you look at the future, we may end up having cubicles. This is in China, and similar is happening in America. We can pop into a cubicle, no primary care facility required. You see a doctor, you have all your image, your vital parameters checked, like ECG, oxygen levels, or whatever. Then with your smart card, you pop next door, and then you get your medicines and you walk home. So maybe buildings aren't necessary. Maybe we're thinking about kiosks or different kind of mobile areas, like mobile CTs. We've used it for years. Maybe mobile access to doctors or healthcare workers is going to be the future. This is my future. This is what I've been doing for the last 5 years. I've been running clinics. This is on the left-hand side, you see my laptop connected to the electronic health record, Cerner Millennium at the hospital, Royal London, with my Attend Anywhere video software platform. So I'm seeing my surgical patients all remotely through video with real-time entry into the Cerner. And of course, I do my ward rounds. I've been doing for 6 years, my ward rounds virtually from anywhere in the world with my Beam system. When I was doing it 6 years ago, people thought it was a bit weird and strange. Now they think it's great because COVID has allowed us to use these technologies. And I go around the ward with this, with my team, teaching and training and seeing patients. We can never be away from the hospital, and therefore we can use these technologies to be with our patients. Talk about remote monitoring and sensors. It's really exciting how we really using technology to monitor patients at their home or in the community. And this is from Time magazine saying that at some point we'll never be offline. Excuse me. What we're seeing is a whole plethora of devices coming out soon, whether it's the Profuser, a small device inserted under the skin to measure your oxygen levels or indeed your blood glucose. We're seeing nanobots, etc. And of course, the Apple Watch 6 has been used widely, measuring oxygen as well as the ECG looking for AF. So we're now seeing amazing technologies in terms of the ability to use sensors in various parts of the body. Of course, Libra system, you all know about it for diabetic type 1 patients with real-time monitoring. It's rolled out, and in the UK, we use it routinely for type 1 patients. But now we're moving on to the artificial pancreas. Now we've got funding for people to have artificial pancreases with remote monitoring. We've seen the LiveCore and other systems being used for AF in the community. And now we're moving to smart clothes, which we have to monitor your temperature, your pulse rate, your blood pressure, and all the parameters in real time. Good for athletes, but also good for people for rehabilitation or patients who have chronic disease at home that you want to manage going forward. So this is the idea. AI, of course, is much talked about, much lauded. And I talk about 3 parts of AI. It's the hype, the hope, and the reality. There's great hype, of course, before that it's going to solve all of the world's problems. And there's hope that we could actually achieve something more in healthcare. Actually, what we're seeing in 2021 is the reality. The kind of use cases are coming out that demonstrate the benefits of AI, but also the limitations of using deep machine learning in clinical practice. What we've seen now, of course, is the use cases. We've seen it in the COVID pandemic with the rapid deployment of the vaccines, of course, and now we're seeing new drug technology and biomarkers being utilized in AI. So it's diagnostics, drug discovery. We talk about chatbots, the interface between a patient and a healthcare system that's more efficient, and of course talk about my own specialty of surgery, and that AI is going to be used there. There's many companies out there all fighting for AI, of course, in the same space, whether they're using natural language inputs like voice technology, your patient data, your biometrics, or operational data from providers, and looking at 4 areas. One is, of course, is early detection and triage, is diagnostics, is treatment management, and of course, monitoring outcome. So those are the areas we're looking at in terms of the benefits of AI and what it has to offer. We've seen already use cases in dermatology, use cases in for example, in retinopathy, also for chest x-rays, images. And now we're seeing kind of the image analysis being used on a wide scale. So I'm not sure these lines on the screen. But anyway, here we are. This is the from the NHS, where we're now open sourced all of our images. So people can access it for COVID and look at that going forward. So now we have companies looking at how COVID can be predicted using AI technologies. I'm talking about these lines on the screen. I'm not sure what's happened here. Anyway, so look at endoscopy, for example. This is a colonoscopy based around AI, and it's looking at detecting the polyps here. So on the left-hand side, you see a screen. You may or may not see a polyp there. Suddenly, the AI will pick it up and show more clearly, and you see on the right-hand side, you see the polyp on the right-hand side. So again, for diagnostic abilities, we're now using real-time AI imaging in endoscopy to look for polyps and stuff. Chatbots, of course, has been really interesting rise in terms of how we interact with a chatbot, whether it's going to be using Ada, Babylon, or many others out there who are now using similar things. And these are like a triage tool, intelligent triage tool, which would communicate with the patient in that sense. If we look, of course, at the further, if you look at our vocal biomarkers, so if you look at our voice is very powerful. This is a study done in America, the Mayo Clinic, where actually patients with ischemic heart disease, if they talked into an app for 1 or 2 minutes a day, the app would predict the onset of cardiac failure 2 weeks before it came out. So preventing an attack of cardiac failure just based on your vocal biomarkers. So the voice is very powerful. We'll see more and more companies using voice technology and AI systems. So I have a number of companies I work in med tech, and one of the companies I'm non-exec director for is Medic Bleep. This is a messaging tool that we've replaced the Bleep with in a number of UK hospitals. We looked at how we could interact better, like WhatsApp, but safe, secure, with governance around it, with lots of tracking systems inside it, task management, and to help support doctors in real time, and nurses, of course. And we're the first company to embed a Bleep system, a Bleep replacement system with messaging in a UK hospital. And we also showed paper where we actually improved access and saved valuable time for both doctors and nurses. So if we look at this next area of technology, it's called extended reality. And this is something that I've been involved with the past 6-7 years. And so if you look at extended reality, what does it mean? On the one hand, you have something called augmented reality. And that's where you have a glass in front of you that you can see out of, you can walk around, but you have overlays of information, rather like a jet fighter pilot. On the other side, you have virtual reality, which is completely embedded into a new world. We can't see the outside world. In the middle, you've got mixed reality. All those three combined, what we call extended reality. And I'll talk a little about holograms, avatars, which I've been using for a while now. If you go back to augmented reality, this is a concept of a glass being produced, of course. These are the kind of things we're seeing being coming out, overlaying information in real time. And you'll see in Facebook recently launched their smart glasses, and others are coming out. What we've got here is a number of glasses. As you can see, the form factor is getting better and better, more powerful devices. Some are connected, some are not connected. But the Google Glass, of course, changed everything when it was launched back in 2012. If we go back to the Google, this is augmented reality using a smartphone. This is medical education being taught and trained using this kind of technology. So here we are, you can see what's been going on, and you can see how you can use your phone as a device. The Android, of course, and has the AR core, and of course the Apple has the AR kit, both designed to allow you to do augmented reality platforms. We've seen this is my colleague Proximi, run by Nadine Harak-Haram, who's working on remote training using augmented reality. And they've just raised about 40 million to increase and empower people around the world to do remote mentoring, remote teleproctoring and training.
We have a colleague in there, and there might also be a vein a bit further lateral, but that's okay. You could just take them where they come.
So this is remote work. So about virtual reality, let's talk about that going forward. VR is not new. There's a number of kind of devices out there that have been around since 1830. But of course, what's happened now is computing power has become so much more powerful now to allow us to adopt VR in a different way. And of course, they are improving readily. We're now seeing amazing devices that are mobile, that means they're untethered to a computer, have 6 degrees of freedom, motion tracking, eye tracking, etc. So we're seeing now this concept come through. We've seen it being used for phobias, anxieties, pain relief, even for women going through labor. There's some trials now showcasing that by giving VR therapy or VR distraction therapy, they can avoid the need for an epidural or open analgesia. We're seeing now used routinely for post-op pain. And so now we're seeing thousands of patients in clinical trials, whether it's in Cedars-Sinai in Los Angeles or indeed on Comfort from Belgium. We've got many, many patients now, thousands and thousands in clinical trials showing the benefit of VR therapy or VR medicine, as I call it. In the UK, we're looking at how we use VR for lung rehabilitation. And it's great for COVID patients who have got long COVID. We can use now VR to offer them the rehabilitation services. So this is the kind of things we're working on at the moment. I've been working in the immersive tech world for 7 years now, and this is my own company, Medical Reality. What we created was a way of teaching and training in VR, which is now being rolled out across the UK and across the world. A new medium of learning where we can actually train people and actually allow people to navigate in a VR environment. This is a surgical operation, a lap chole, for example. You can select the menu system in the VR. You can interact with it. You can go into the operating theatre. You can engage, you have exam assessment tools, and there's now a huge interest. Health Education England in the UK has now put forward £4 million to bring VR training across the UK. So we're really now highlighting the importance of immersive tech. This is what the VR will get in the operative theatre. We're creating 360 degrees with hotspots and interactivity so that you can now learn and interact with that environment. It's not just about the learning towards the operation, it's also about simulation. So the idea is now simulation will change enormously with VR content. The old simulators cost tens of thousands of pounds. This will cost next to nothing, maybe a few $100s. So you can actually now train yourself in VR, and you see the simulation. You can practice the CGI animation. This is a chest drain being inserted. You can train, assess yourself. So OSCE-based training is going to move on as well. We're seeing it used now for orthopedic training in the US, also VR. And we're seeing now companies really revolutionizing the way we train the surgeons of the future using VR platforms. This is just a mechanism of learning. And we're seeing now the effects. PwC, my friends at PwC did a report, and they showed actually that VR training was much better. More engaged students, faster, more confident, more focused, and actually it's going to be much better in the future. If you look at mixed reality, this is mixed reality we're looking at. So these are devices like the HoloLens, or in fact, the Magic Leap. The Magic Leap 2 has just been announced. So these are devices that allow much better computing power. We call it spatial computing to allow yourself to see in that environment. These are kind of examples of mixed reality. This is where you have surgical planning involved using CTs and MRIs. As you can see, this would make surgery more precise. This is my friends from Japan, Maki Sugimoto and HoloEyes. We can now pre-plan surgery in real time. It's getting better and better. And the surgery of the future will be based on these kind of computer vision, mixed reality, and AI and data interventions. So I work with Vodafone as the Connected Health Ambassador. Some of that work we do is around smart ambulances, connected ambulances in the community. So this ambulance is connected to through a HoloLens 2, a mixed reality device connected to the 5G network, and the ambulance crew can real-time relay information back to the hospital to get valuable insights into treatment plans. So this is the kind of thing we're looking at rolling out as we speak across the network. As a teacher, I've often thought how we do things differently. I remember if you go back a few years, I did the world's first Google Glass operation, the world's first virtual reality operation, and the world's first holographic operation. These are all world first, pushing the boundary of what was possible. Because I always felt that being remote was ideal and we should not travel, but actually embrace technology. This is us last year during COVID. This is Bart's Medical School. And I was bringing students into a kind of a distance lecture, social distance lecture theatre, 70 at a time. I was on the ward with my mixed reality headset. Anastomosis. And so what's happened is that sometimes with this staple line by the pancreas, you get leaking of fluid, pancreatic fluid, and that's what you're seeing on the drain. And the drain helps evacuate it without accumulating again. So what we're seeing is me remotely training using 5G networks to a lecture theatre. It could be here, it could be around the world. And it's a global thing that we're thinking about. Next up, of course, is these avatars, holograms. So that's my avatar, the blue polygonal image. That's me in a virtual world. And you'll hear more about the world called the metaverse, we'll talk about in a moment. So this is where the real futures lies, okay? And you see this going forward. Of course, we want to, Captain Kirk actually just went to space a few weeks ago, didn't last week, with the Blue Origin team run by Jeff Bezos. And actually think about transporting yourself. We've seen during the pandemic where actually we've been limited by traveling. And so we've got to think differently. This was me. If you look here on the top left, I'll play that for you and put the volume up. Hi, everybody. Hi, Shafi. So the HoloLens itself really allows us to reshape the way we connect people, we communicate with people, also to be used in teaching and training. Initially, when you put the HoloLens on, it feels a bit strange, but actually within a few minutes, it becomes quite normal. It feels. So what we're seeing here is me in operating theatre in the Royal London. Two other avatars appear in my world from a Tata Memorial Hospital in Mumbai in India, and also my other surgeon who's based out in New York, all connected together with joint assets so you can be in the same room together in real time. Of course, if you look at the next video on the right-hand side, you see me as my hologram appearing out of nowhere, being recreated in mixed reality. So you see me now on the right-hand side in mixed reality appearing, and you can be anywhere in the world, connecting, competing, and working, or even telementoring people around the world. And the bottom, of course, you see the hey, John, how's California?
Hey, Shafi, it's really beautiful here. How's London?
London's great. Should we have a virtual handshake?
Yes, of course.
So, as you say, I've been conversing for a number of years as my hologram, as my avatar, really being futuristic, thinking about John, what that looked like. So the word metaverse comes in and you see more and more of that being announced. So we're going to be launching the world's first surgical metaversity, learning in this virtual world. And they call me the virtual surgeon. So some of you may go to Dubai soon. I hope you managed to see the Expo 2020. I'm going next month. This is a video that I took from the World Government Summit, which I spoke at to just before the pandemic. And actually, it was their depiction of the future of surgery in the Futures Museum in Dubai. It's about 3D printing, AI, computer vision, and image analysis, etc., all based around the future of the operating theatre. The concept of digital surgery is rather new. We've talked about digital health for a long time. Digital surgery is a new concept. And I call it the 5 pillars of digital surgery: the robotics, enhanced visualization, advanced instrumentation, connectivity, and of course, it's machine learning and analyzing that data. This is the concept of digital surgery. And we look at now robots coming in, becoming smaller, more remote. We've seen now robots become more affordable around the world. And there's a huge, there's Johnson & Johnson, there's Medtronic now, Cambridge Robotics, of course, Intuitive and others, all vying for robotic space. And we'll see more and more robots being used globally. If you combine robots and 5G technology, you see that in China, this was even 2 years ago, we saw the world's first trans kind of continental surgery performed using 5G technology. 5G, remember, can download things at 1 or 2 gigabytes per second, and of course with a latency of 0.1 millisecond, which allows immediate recognition. There's no delay in the transmission. The whole interface between the robot or computer systems and humans is evolving. It's getting closer and closer, and that concept is changing. You've heard of course, Neuralink from Elon Musk, the brain-computer interface, the BCI. We're now going to impact the brain and take out data, influence decision-making. We're seeing already being used in different ways. Many companies are out there working on how do we improve the connection to our brain through direct links. This is a colleague of mine who was controlling his arm through his musculocutaneous nerves and also, of course, his upper muscles, etc. So already that BCI is a real thing. We're using real bionic technology almost. And this is a colleague of mine who passed away, unfortunately, last year, but he was one of the first to have this amazing arm that was connected, in fact, to his brain. As we go through, we're going to change humans, become more digital. We're going to create digital humans that look like us. So are we ready for a healthcare system where we have digital humans, digital twins, going to help us support our kind of clinical practice, or indeed allow us to see more patients more quickly?
Hi, I'm Roman, a digital human brought to life by soul machines. With me, you can experience AI like never before because I learn and react emotionally like humans do.
The last thing we look at is the very future. We're now going to be going to Mars at some stage as an interplanetary species. It's kind of the future with all the money invested in the future of space travel. What it does do, it impacts healthcare in the world here. 3D printing has come a long way from the pricey, platforms before to very cheap and affordable. We're seeing now this use of 3D printing for maxillofacial surgery, for orthopedic surgery to help support how we perform operations. But of course, they sent a 3D printer to space. This is a team called Made in Space a few years ago. Actually, they printed out devices that would help people in space, for example. So for example, one of the astronauts broke his finger and they produced a splint by 3D printing, and actually he carried on working. It's that kind of thinking that helps the remote areas in the world today that's made in space. We've seen the design of bioengineering and I guess reconstructing what bioengineering might be with its 3D printed kidney, 3D printed heart, and of course, skin. All these areas of transplantation might change the future. We don't need transplants anymore, but we create our own array of transplanted organs, etc. This is an exciting part of the future. To our transplants, of course, transplantation is changing. We're seeing now drones delivering goods around the world, and also now this is in New York, where a donor heart was sent from one part of New York to the other for a transplant, much faster, much quicker. We're now seeing that also used in the UK and others to transport vital equipment, and we've seen that, of course, in parts of Africa and Asia. If we interact with people remotely, we'll see kind of avatars coming in so that we can see people. Hi, Dorian. So nice to meet you. So I'm Dr. We can see people connecting in different ways with people with a kind of resemblance of human being. Now we're using other things to transport people, paramilitary and paramedics, of course, around the world, whether it's using these kind of technologies as we go forward. So really, this was really a quick show and stopgap of the things that we've been thinking about, people at the forefront of innovation, and how they are going to think about how technology will make healthcare, I guess, more accessible, more affordable, and ultimately more equitable. That's kind of what we want to achieve. And I guess I'll leave with the last final quote. It's from William Gibson, an American-Canadian author who coins the term about the future. And I think realistically, the future is already here. And I guess part of our mission now is to persuade other people to innovate, to think differently outside the box, think how can you individually do things better. And I guess one of the key messages I'll leave you behind with is how you want to become a disruptor. If you think about exponential thinking, I'd love all of you to go away from today's talk and become exponential thinkers and not linear thinkers. Linear thinkers aren't changing very quickly. The world around us is changing at pace. So if I give you an example very quickly, if I said to all of you, let's take 30 linear steps together, we'd walk about 30 yards. You understand sequential steps. If I said to the audience now, let's take 30 exponential steps together, we've gone around the planet 26 times. That's the pace of change. That's what's happening around you. It's for us to adopt, assimilate, understand where that technology is driving us. If we go back in the past, of course, Islamic brothers from the past were innovative. I remember reading up about the history of Islam and medicine, and we've kind of had a hiatus for about 1,000 years, but we were really the pioneers of innovation in surgery, in medicine, and healthcare. And we've stopped short a little bit in the last 1,000 years. We need to use our joint understanding to ensure that we are also powering that healthcare service forward. I'll leave it there and I'm happy to take questions. Thank you.
Mashallah, mashallah. Thank you, Prof. Shafi. We've definitely need to think outside the box. We thought we're pretty advanced here in Australia, but unfortunately we're way behind. I've actually had the pleasure to operate with Prof. Chan at Liverpool Hospital and do robotic surgery in OBS and Gynae and Gynae-Onc, but we're nowhere close to what you have just described. We definitely need to think outside the box. I think there's a lot of advantages, especially here in our country, to use virtual technology, especially to connect rural health to mainstream hospital in Sydney and other states. Now we're gonna look at the Q&A, and may I ask if Dr. Imran is still with us? I think he is. So can I ask Dr. Imran and Dr. Shakib to please help me scan the Q&A? And if anybody wants to raise their hand, we'll be more than welcome to take questions to address to Prof. Dr. Imran, would you like to start? Or Dr. Shakib, do you have any questions to address to Prof?
So we haven't had any question in the chat box yet. I think, as you mentioned, that Dr. Shafi has explained the digital transformation and future of digital health. I think a lot of us is actually quite behind with the digital progression of the health. I think it is very interesting the way he showed and so advanced the technology, and in the future, I could just remember in one of our poets in Bengali, and she was a very renowned poet in Bengali, and she said that আমাদের যুগে আমরা যখন খেলেছি পুতুল খেলা তোমরা এখন সেই বয়সে লেখাপড়া করবার মেলা আমাদের যুগে আমরা যখন উড়েছি শুধু ঘুরি তোমরা এখন সেই বয়সে কলের জাহাজ চালাও গগন জুড়ি. That means at our age, when we used to play with doll, at your age you go to university, and our age when we used to ride the kite in the sky, now in your age you fly with a plane. So this is what we are at the moment. Dr. Shafi is saying that we are in our age in a consult room and dealing with patients where the technology is going far, that people operating in 50 kilometers away and the patient is in the other side. I think the COVID has opened a door that, you know, Dr. Shafi is showing that how he could teach from his theater and from his university millions of people far away. I think we, the Australian Muslim health professional and global Muslim health professional, could utilize these tools in the future to teach our Muslim brothers and sisters across the globe and make them efficient, so that, you know, we can be, you know, embracing this digital technology in the future, and we could be in the front line. And Dr. Shafi Ahmed is one of the example. I think some of the brothers is raising the question. So Brother Zain, because we requested people to put the question in the chat box. We haven't seen any question in the chat box. If you have got some time, so we could allow some.
I have a couple of questions here sent to me. I might just address them to you, Prof. Yes. One of the questions was about the ethical issues that you have encountered when initiating those advances.
Yeah, that's a really good question and a vital question. So I think one has to be sensible. We drive innovation, of course, forward at pace. What we need is a system that allows you to innovate quickly as well. So when I was doing the world's first Google Glass or virtual reality surgeries, whatever, first of all, I had a very supportive hospital and the CEO. And what we did very quickly, understand what were the barriers to developing and implementing that change very quickly. We worked with the governance team, the ethics team, worked with the legal team, looked at the legal framework, which was way behind current technology, looked at how data could be shared or stored. So very quickly we understood what the problems were. And what we did, we mitigate those risks as far as possible. Okay, there is some risk, how do we prevent it as much as possible? And we've got patient engagement and patient consent as well to ensure that they were compliant. So actually, you can do it quickly. It depends on the healthcare system supporting you to innovate and taking a small amount of risk, but mitigating it as far as possible. That's all that you can do. Otherwise, you stop. If you look at clinical trials and research trials, they take 7 years for fruition. Rather than 7 years of a randomized trial to showcase its findings, the world has moved on 100 years almost, right? So it's too slow. You've got to rethink the model of science, research, translation, and also have systems that support innovation at pace and to allow scale. And that's what we're seeing now more and more. And I guess the NHS is now working better in that sense, but those barriers you have to confront head on and not shy away from them, because they are difficult questions to ask. But that's the way I did it, and I had complete support, and it was safe ultimately for the patients and for the outcomes.
Definitely. Thank you, Prof. There's another question here, or a comment from Dr. Ahmed. Does this potentially mean surgeon will potentially not have to travel overseas for training and certification? And is virtual presentation in theatres and supervision will be the new approach to training, not readily available in one's home country?
Yeah, so I think if you think about outside the box, these kind of technologies allow the democratization of surgical training. No one's saying it's taking away the face-to-face element and the real practical procedures. No, not at all. That's still vital for the practice of medicine and surgery, of course it is. What we're saying, these technologies will augment the experience, improve access, allow people to be taught remotely. For example, let's take an example. You go on a course, I don't know, before you travel for a course, take 1 or 2 days off work, yes, you'd spend a lot of money and accessing a course to get certification, for example. We're now moving to a virtual world. That's not necessary anymore. You get the same qualification by doing virtual. And these technologies might allow you to do more sophisticated simulation skills virtually, for example. And that's the benefit of it all. Why do you have to travel? The other thing is about sharing knowledge. So one of my things I've been really strong on and keen on is how do I scale my knowledge? I've been really fortunate, alhamdulillah, to be in London, to have a good career so far with good experience. So how do I share my knowledge on a much wider scale? So using technologies, I've shared my experience with millions of people around the world, you know, who've just tuned in, watched me do a cancer operation or something else, help improve standards. I've traveled a lot. So I've done a lot of humanitarian work. I've spent 7 years in Gaza working on training, education, building cancer capacity in Gaza itself. And a lot of that I'll do remotely now. We do training. I took VR training into Gaza, and we do take some visits as well. So I think all these technologies augment, support, improve access. It's not replacing clinical work, and they'll make ultimately healthcare much better, because now we're going to be able to assess a surgeon's performance using AI and data. We'll be assessing the quality of the teamwork in the theatre itself. We've never had that data before. So now we're in a new world where we can actually be much more precise when things go wrong and reevaluate our techniques and ideas. So it's definitely a better place to be, of course.
Definitely. Now, you've mentioned your project in training doctors in Gaza, Prof. Would you be able to tell us a bit more about it and whether you have any plans to expand that project to other countries?
Yeah, of course. So the story was I was invited to go to Gaza after the war in 2014 by the Ministry of Health and a charity organization called Medicaid for Palestinians. So I went to West Bank, I went to Gaza for about a week and a half. I wrote a plan of what I think was necessary to improve surgical training, improving cancer training across both West Bank and Gaza. And alhamdulillah, they were very fortunate. I got a grant of £1 million to implement that change over the last 7 years. So for the first 3 years, we did programs of train the trainers. We did laparoscopic skills, and we did basic surgical training. And we implemented those changes so they were now self-sufficient and trained themselves by building capacity within the Gaza hospitals. The next step was to improve cancer work. So for colorectal cancer, we took teams over to operate, live stream, training the senior surgeons and also the junior surgeons who are going to be the next leaders of Gaza healthcare. And we create virtual MDTs, cancer MDTs, and build capacity. So we've done over 50 to 100 operations now with a local faculty there, giving them the support. My view is all about building structure, supporting from afar, but it has to be self-sufficient. And that's been my model for the last 7 years. Alhamdulillah, it's been very successful. Now we couldn't go last year, 18 months because of the pandemic. planning on going next year again, starting our travels. And there's a cancer conference coming up, which I'll have to share the link with you, to look at how breast cancer, colorectal cancer is now being completely changed in Gaza to build the capacity within that country itself. So I think it's been very successful. Please do come to the conference in a couple of weeks' time and see what the brothers are doing there, of course, brothers are doing in Gaza.
MashaAllah, Jazakallahu khairan. This is amazing.
Yeah, no, so it's one of those things I think we've been very fortunate. And I was in a position where I could impact and lead those projects. And then we want to build a cancer hospital. So there's a Turkish hospital that's been built about, I don't know, 5 years ago, but it's empty, never being used because they didn't have the money to actually staff it and make it work. Beautiful hospital. And so that's in central Gaza City. And then we've suggested they build that to cancer hospital. And because remember, 2/3 of the patients from Gaza who have cancer diagnosis can't leave Gaza to get their treatment because they won't get permits, 2/3. So that is a real terrible catastrophe for the patients, right? And so how do you manage them? So I'd say despite the barriers, we build that capacity in Gaza, give them the experience they need and the skills they need, and we support them where we can. So those patients if they don't get permit, they still get quality treatment, whether it's surgery, chemotherapy, radiotherapy, or even immunotherapy. So it's building that concept. So hopefully we'll see a new hospital being opened next year that will be dedicated to cancer, which I've been striving for a long time. The Ministry of Health now has agreed in principle. And so hopefully we'll see that care can be maintained within Gaza itself.
Inshallah, to many more successes. Now, you've talked about the project in Gaza and other countries. What are some of the issues that you encountered? I'm pretty sure internet and connectivity there must be an issue. How did you manage to overcome that problem?
Yeah, really shocking. The internet isn't great, right? So they have at best 3G connections, sometimes 4G if you're lucky, and 5G is never going to happen for a long time. So I think one of the things I'm very keen on is something called frugal innovation. So how do you take our concepts and use it in a place where it's a poor resource setting, poor connected systems? Some of the systems we use actually require very low bandwidth. So I'm working with a company called Rods & Cones in Holland with glasses that can stream and actually help train, etc. That can be based purely on 3G signal with stable connection. So we've got technology now to a stable where you don't need as much data. It's from the cloud, etc. So you're using technology in a different way. I also remember some of these ideas that you're promoting are going to, so for example, some of the food innovation we've created, when we're there, we connected some hospitals within Gaza now through actual real lines. So it's more reliable for us, okay? So we connect a few hospitals so that we can train people remotely as well. So you're saying, what can we do today? We also have to empower them for tomorrow. And actually what I think of almost is leapfrogging society. Some of the ideas they have are way better than what we think. If you go to Africa, mobile money has been here for the last two decades, way advanced of Western civilizations, okay? So how do we use some of those ideas? So in Gaza, you'd be amazed at this. There's there's something called the Gaza Geeks. So Google have come to Gaza with other big players, creating a hub of innovation. They're saying, can we use this immense talent? Because 99% of people are literate, right? It's the highest literacy rate in the world. They all go to university, they're educated. So use that power of people that are there, who've got computing, science backgrounds, whatever, bring them together and create ideas to empower Gaza, also to export their ideas outside with apps and technology. So this was reverse engineering in some ways, reverse innovation. And what you're seeing is amazing technologies that they're coming up with, amazing ideas and concepts. So it shows that actually even the barriers they have can be overcome by empowering them with the skills they need and support they need. So I'd say that it's frugal innovation, it's supporting local workforce to improve their experience and skills, using them to then translate on a global level. And you don't need to leave the country almost.
MashaAllah. Definitely a massive leap forward to the future. Now, a very, very good question from one of our young listeners. Can digital medicine possibly replace human doctors in the future?
Yes, so will I be ever replaced? Look, I think the word replaced always causes a lot of controversy. We shouldn't talk about replacement. No one's going to replace doctors ultimately. We have unique skills, and there's still a long way to go before we reach a point called singularity. This is something you might read up on. So the point of singularity is the point where computers are more powerful than human behavior, and human beings. Okay, that's the point of singularity. And there's a great book by what's it called? The engineer from Google called Ray Kurzweil, and he talked about this singularity concept. What I suggest you all say is about augmenting, it's supporting, assisting. That's what we're using technology for, to make our lives easier. For example, automation is very important. Look at electronic health records, helping us do voice technology and voice dictations. All those things would help us in some ways, right? It won't take away the elements. AI, for example, where does AI come in? AI will help diagnose images to a large extent. So a radiologist who's looking at many chest x-rays, most are normal. So how do you take that bundle of work away from a hardworking radiologist so that it becomes very efficient and very precise, and let the radiologist work on things that he needs to work on, the stuff that he's trained for, experience allows. So it's repurposing the workforce. That's a smarter workforce. So I think it will allow us to do that. The other thing, of course, to say about these technologies and how it augments our work is cost. Look, I've been around the world and each country has the same problem. There's no more money, right? No one's got cash to throw at healthcare, right? So that's not the answer. The answer is, okay, with that existing money, how do we repurpose it to make it smarter, more efficient? How do we use it in a different way? How do we change the way the patients behave or are treated at home or community? So that's where technology comes into it, assisting the healthcare infrastructure, supporting us as individuals in healthcare. So replacing is a word I would never use. And I would say we're really augmenting, supporting, improving our clinical care. And that's what we need, of course.
Definitely the right approach. Now, I'm getting a lot of questions. I'll try to go through them all. Now, we haven't talked about the cost, Prof. When do we expect digital medicine to become affordable and a bit cheaper than what it is now?
Okay, so now is the answer. So I'll tell you why. 18 months ago, I'm pretty sure everyone in this room were not doing video consultations. It wasn't even their mindset. Okay, never thought about it, wasn't part of it, we're not interested. Suddenly, you will become experts on video technology, right? Whether it's Zoom, Teams, or whatever you're using, right? So that's changed. And what's now happened? That's been reimbursed. Suddenly, it's changed the way the tariff is placed. And it's simple, cheap technology has been there for a long time. Now we're using it. So that's the first thing I would say. Secondly, we do have to be understanding how we reimburse technologies. That's going to be the key. Usually at the beginning, there's a capital investment required. Yeah, if it's like a robot or something else, it's capital expenditure. And then, of course, the cost comes down. There's always a curve where the cost comes down. What we're seeing now, of course, is cost becoming cheaper and cheaper. Whether it's using a workforce around the world, IT experts, whatever, we're using cheap technologies now that can be scaled very quickly. So the cost isn't as much as you think it's going to be. So, and of course, as time goes on, the costs come down. But if you look at healthcare, how it's changing from face-to-face to remote, that money also needs to move in that direction. So repurposing the expenditure required for a healthcare system of 2019 to 2022. What does that look like? What does that relationship look like in terms of integrated healthcare systems, how we obtain healthcare, what's the first point of contact? So it's that now we need to grapple with. No one's got the answers or solutions, but it's happening. But I think what will happen, it will make healthcare more affordable, much more cheaper going forward, because technology can scale very quickly. And that's the key. Excellent.
Another really good question, Prof. We've talked about technology and moving forward. What about clinical skills? Now, I guess if you're having a consultation, which we're doing a lot of telehealth at the moment here, especially in primary care, what about examining a patient as per se? Now, you've talked about robots and avatars. These sensory modalities, how can we overcome that?
So look, I don't think we need to overcome that. So our basic tenet of medicine at the moment, for the foreseeable future, is still face-to-face clinical contact. No one's saying you replace it. So clinical skills, for example, your hand skills, you're looking, seeing a patient face-to-face, examining them, abdominal examination, whatever. That's still fundamental of who we are. There's no question. But you can augment and improve it. Yeah, and you can shorten training, improve training. That's the key. And as I said before, all these are supporting these ideas. So do we have to examine every single patient? Of course we don't, right? An AI system could, for example, look at a cough or take symptoms or triage and allow you to work out which ones are relevant or not, for example, right? I'll ask you how many chest examinations that you've done, patient with cough has revealed anything. Okay, I'd say very few, right? You do the same thing based on the history, based on the symptoms and the story, okay, in terms of referral. So that can be managed in a different way. In terms of training, let's take example last year. At medical school, our clinical students were having no face-to-face teaching. They're all at home, virtual, okay? So suddenly you're saying, actually, face-to-face wasn't working. We had to think differently. So our students were getting this remote training, at least helping them understand clinical skills, all right? And experiencing it in spite of the pandemic. If we didn't have those availability, they'd be at home doing no work for a whole year because we've stopped them from working. So there was an opportunity to think differently. And another thing about medical school curriculum, I'd like to add to this, is that it's so archaic. So you and I have all gone to medical school, and medical school is still 5 or 6 years training, right? It's still largely based around the basic sciences and clinical work, right? But why does it train 5, 6, why does it take 5 or 6 years to train a doctor? Why can't it train in 4 years, 3.5, 4.5? No one's ever thought about changing the framework. They need to learn as much as before. Do we need to train them into innovation in digital health and technologies and entrepreneurship? Because that's the world they live in. So we can't change, the curriculum hasn't changed, but yet the world is changing very rapidly. And medical school and undergrad training is really slow in adopting that. That's nothing we need to change to create those doctors that we're saying need telemedicine, right? We need to understand these ideas we're talking about. So it needs complete change from the ground up for a new way of thinking. And that's what I've been doing at Bartsex, Imperial X, at Bradford, at Harvard, and other places. Say, look, you've got to think differently and challenge the dogma and tradition of education.
Excellent. I have a very interesting question here about allied health. Prof, how do you see allied health professional contributing to the world of digital health?
Yeah, very important. So look, I mentioned one of the key parameters of MDT. It's about this new workforce. Yeah. So let's take an example. I showed the Lancet Commission with this report back in 2015, saying that we need about 3 million extra surgeons, anesthetists, or healthcare workers just to have surgery that's going to be equitable, right? So we don't have 3 more million surgeons, right? They're not going to be trained in the next 10 years. So how do you repurpose the workforce? We've seen during the pandemic where the workforce has gone into the acute care to manage the pandemic. Surgical trainees, surgeons, whatever, they went to the front line, retrain themselves to use ventilators, for example, yeah? Yet other people, allied healthcare professionals, come in supporting that, proning, ventilations. So the workforce needs to be used in different ways. A smart workforce. Can we remobilize that workforce to manage the acute epidemics that we want? For example, we have a problem now in the UK. There's 5 million people waiting for elective surgery, 5 million. By next year, it'll be 10 million. So we don't have enough surgeons in the country or platforms to do that. Can we retrain the workforce to differently? Can we send some of that stuff we've done by other people? I've always said, you know, if you look at China back in the 2 decades ago, a lot of the microvascular operations were done by 16-year-old girls because they had nimble fingers that came to anastomosis. Do we need to train people for 15, 20 years to drain an abscess or do a hernia? Could we do something differently? Get some of the people as technicians, like endoscopists now, nurse endoscopists are coming in, okay? Absolutely, it makes sense. So also it upskills them. They are more ingrained in the healthcare system. So my question is, how do we use that smart workforce? And the workforce is changing. The workforce doesn't want to work 30 years in one profession anymore. They want to have what's called a portfolio career. They will change. And human behavior suggests every 5 to 10 years, you to upskill, change, look at something different. What we created is a workforce that's disenfranchised because you get to the career, but how do you sustain that interest for 30 years and keep going without empowering yourself to think differently? So 2 things come to mind. John Scully, who's the ex-CEO of Apple, was a friend of mine, and he used to say that as CEO of Apple, he used to keep doing different things every 5 to 10 years. He just got bored. He needed to do something differently, etc. And our workforce in the healthcare also need to change every 5 or 10 years to embrace that change. So that's what I'm saying to you. In fact, even look at me, now I'm kind of got to the top of my profession. I have now gone into more health tech, innovation, global health work. I keep transitioning from different parts. That keeps me interested and keeps me in healthcare. So that's kind of, and the young people tell you, the young population is they're not going to work 30 years like you and I. They're not interested. They're going to work differently. So do we have a healthcare system that supports that different kind of working, part-time working, remote working? Have we managed that yet? We haven't. So we're driven by where the demand's going to be in the future. And the youngsters are changing the way we're going to think about creating jobs for tomorrow. The jobs aren't suitable and they're not relevant that we advertise today for people coming in. And that's why they're leaving in their droves.
Exactly. And I know for a fact that, for example, here in Australia, physiotherapy courses have moved way ahead with using technology in preparing their students for the workforce. So we're moving forward, hopefully, but not as quick as we should be. Now, there's another question about how do you see digital health helping us living with COVID? Moving forward, your thoughts and opinion, please, Prof, especially with long COVID, Prof.
Yeah, really good question. So look, the first thing is about, so COVID's opened the door of innovation and technology and translation. There's no question. The door's not going to be closed again. And the question, it's giving us a springboard almost to start off at a new level. So we have embraced change, we've embraced technologies. So long COVID is an issue. And I've suggested already, a lot of it can be managed remotely. Some of it can be managed just by virtual consults, regular consultations, but also things like rehabilitation I mentioned earlier, like the VR thing was looking at from North Lincolnshire, looking at long-term rehabilitation of the lungs from COVID patients, for example. So part of that can be done remotely. So I think it's more about the overall picture where COVID has left us. It'd be a shame if if we go back to the old normal after COVID, it would be a shame. I think it's given us a wonderful opportunity to springboard. They call it the new normal, but what we like to call it, it just means that we can now think much ahead. What we've seen is the change of rules and regulations. The regulatory framework has changed, the way we design innovation, the way we introduce innovation, the way we also, the other thing is about having the right teams now. So I often talk about collaboration. Collaboration is the key word in the future of healthcare. And that means working with other stakeholders. And that means working with industry partners. What we see is industry now comes into healthcare, supporting with their skill sets that's different to ours and helping us shape their healthcare system. I'd love to see more and more of that integration, more industry partners coming in to support. Before there were barriers that people were scared of having outside companies coming in, I'd embrace it because what they create is a new way of thinking. So when I'm doing these innovation kind of courses I run, we bring teams together. You know, we run Dragon's Den pitches, we run hackathons, try and bring people from IT, engineering, from medicine background to work together to collaborate to see what that future looks like. I'm hoping that's going to be the same as we go forward. And also the government's also changing their ways of thinking around COVID. There's more money available, first thing, more money being thrown at healthcare for digital technologies, for translation. So the money's there. They've changed the policies, they've changed the framework for you. They're supporting people. And it'd be a shame if we as medical doctors or healthcare workers weren't up to that challenge to embrace that change as well, to offer innovation. And last thing I'd like to say is that how do we bring innovation to the heart of an organization? At the moment, we are literally based around outcomes, numbers of patients seen, crude metrics about how you're performing. What about if we said to you, okay, how can we help you innovate in your practice? What can we do to support you? What change would you like to make? And there's funding available for you. That's the story that we need to get to, where each of you are individually empowered to innovate or change. Innovation is not about technology. Innovation is about change, improving, redesigning, rethinking, reforming. And we don't do enough of that because we're so pressurized in our work, we don't get time. So back to long COVID patients, this is all part of that long COVID strategy. That's allowed us to do this, I think.
Mashallah, mashallah, definitely lots of food for thoughts. There's two brothers who have their hands up. I might ask Dr. Mohammed Munir Zaman to ask his question.
Thank you for the opportunity. It's a great talk, Professor Ahmed. I'm in Adelaide in South Australia. I deal with lots of, I work with our Aboriginal people and both in the city as well as in the extreme remote areas. So I'm in primary care, I'm a general practitioner. So from obviously you mentioned lots of high end of the technology, how we can embrace this technology in primary care so that we can better support like a tertiary system. You mentioned about the small hospitals. I think the concept is great. To support that concept, we obviously need to use our primary care system, general practice system a lot, so that we filter all those work so that you get your job done properly. So my sort of question, or basically I'm asking your ideas how these technologies can be used in primary care.
Okay, so that's a really great question. I think you mentioned you work in rural communities, the Aboriginal communities and stuff, and that's kind of where I think a lot of these technologies will be best served. We talked about earlier about frugal innovation, requiring low bandwidth, low connectivity. We looked at how mobile phone technology can offer some of these solutions, whether it's app-based or whatever. And so I think in terms of connecting people, that's going to be the key. So a few parameters I mentioned before. One was connected telehealth triage. That's completely obvious, simple answer of a solution using maybe chatbots and triage systems and perhaps some virtual consults. That's one way, simple. Then, of course, if you selected patients, find out, okay, who needs to be managed in different ways. Remote sensors aren't particularly expensive anymore and became more and more affordable. How do we help support patients in the community much better? So I think primary care is exactly where these technologies should be used much more, because what you're doing, you're the gatekeeper and you're managing patients with chronic disease much more than secondary care. So your intervention around all these technologies and just about redesigning pathways, but not about technology, redesigning a pathway clinical outcomes so that less patients go to hospital, that they provide more care at home if necessary. And so that whole concept makes sense. As I said, with Vodafone, we looked at that as a concept of care at home or care in the community, primary care. Our emphasis is around mental health, around well-being, around managing chronic diseases, the 3 areas that are absolutely crucial to get right. So what I would say to you, the government's now looking generally, repurposing some of their budgets into managing people in that with a pandemic. So you've got one opportunity in a sense to promote that, drive it, improve it, and showcase how you're going to be changing your own primary care system and practice. I'm not sure how primary care works in Australia. In the UK, of course, we go into what's called integrated care systems, where we're connecting more of these organizations together to allow that new way of working. So I'd say absolute primary care is the focus. It has to be remote care well-being, and the technologies that are available aren't particularly expensive. But what you also do is redesigning pathways for them. So it's a bit of everything. So I've got a colleague who works in West London here, and he's the head of innovation in primary care. He's saying a lot of these ideas and the Apple concept of working in primary care and bring innovation into a community in West London that's quite poor generally and less resourced. So I'd love to share that's a much bigger question and decision to talk about. I'm happy to talk offline about that. But absolutely, that's where I think a lot of these ideas will have maximum benefit.
Excellent. Just looking at the time now, I'm sure you're very tired, Prof. There's one more question from Dr. Amr. If you don't mind, Dr. Amr, maybe sending me that question and we can ask Prof. Shafi to answer it privately for you. I might just now ask Dr. Al-Abbas to make a small dua. Thank you so much, Prof. Shafi. It's definitely been a pleasure hearing about all this innovation. We will definitely
concluding remarks.
Sorry, what was that?
Concluding remarks by Brother Habib before dua.
Yes, Brother Habib.
No, thank you. Thank you so much.
Thank you.
It's been indeed fascinating. You know, it's been an hour and 20 minutes, 25 minutes, and I can't believe that it's been so fast. We just close to the session, and I wish we could have continued a bit longer as well. I just, I'd like to take the opportunity to thank Professor Shafi for the wonderful talk today. He's provided a fascinating overview of how innovations in digital health are reshaping how healthcare is accessed and provided, introducing a new landscape for healthcare providers to navigate. And he's really given some great examples, some customization, also told us way forward, and also actually left us thinking more, as you said, how we can actually think exponentially rather than linear. And it's something really stuck to us, and it's indeed it's really thought-provoking. thank you so much for your time. Also, I must mention that because of the daylight saving time, we did have a bit of a mix-up, and he still managed to help us, and get on board fairly quickly with a very short notice. So sincere apology. That's typical of, how we operate in Australia. Different states have different times. Some have daylight saving, others don't. And we just can't seem to agree on anything, including border closures and open and all that. I won't go all that, but I think you know how it is. So thank you so much again. I also would like to thank all the team, or all the people at Australian Islamic Medical Association, our wonderful host today, Dr. Zina, Dr. Afzal, the president, and also the team, who all of them helped us putting this together. And most importantly, all our participants today. It's a Saturday evening, first week after the freedom, after 5 months. And I think everybody wanted to have a dinner or something out, and still we have quite a large number. So I think it just now make us realize that why is it a bit less than we might have thought, but it's still great numbers. Thanks everyone, and especially thanks for Professor Shafi again. We would definitely love to have you back again, and keep learning from you and listening from you, and hopefully we can implement some of those strategies, especially helping some of those vulnerable, marginalized communities and developing countries, and all the examples you've given in Gaza and others. So thank you so much, and thanks everyone for joining.
Thank you, Dr. Habib. Thank you all for all the participants. May I ask Dr. Al-Abbas to make a small dua at the end, please?
Jazakallah khair, Sister Zina, and Jazakallah khair, Professor Shafi Ahmed. We're really proud of you as a Muslim, and as a good example to a good Muslim. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. السلام عليكم ورحمة الله.
Thank you, Dr. Al-Abbas. Thank you, everyone.
Jazakumullah khair, everybody. We close the meeting formally. IMA members can stay behind. If we will have a quick review and just the informal discussion. But those who need to go, they are most welcome to leave. I'll ask Brother Asif Raza to take over this part of review. Brother Asif, you still around?
Thank you very much, Dr. Afzal. Thank you very much for that. It was really a wonderful evening, wonderful presentation, and definitely food for thought for all of us. And thank you very much, Dr. Zina, for conducting this meeting. You kept everything in check, mashallah. Jazakallah khair. Thank you very much for all that. And Dr. Habib, again, mashallah, well-conducted meeting. I know that a lot of hard work went into that meeting, organizing everything, but I thought it was just a spot on. Few things which are not in our control, of course. We never expected when we organized this meeting that we will be free. And then, subhanAllah, the first weekend when we are free, the large number of people registered, but obviously, probably they chose to enjoy their family time rather than coming into this scientific meeting. For this purpose, we just wanted to have a quick review, maybe a debriefing. Dr. Zina, do you have to say anything in terms of all of it?
Still there, I think there's still members around or not. I don't know whether do you want to have just with the team or there's still 20 plus.
Oh, yes. Okay. I thought probably Dr. Afzal requested everyone who are non-IMA members, yes, please, if they can, because the meeting is closed. So I will request non-IMA members to please log off. It is just the IMA members review and debriefing. Thank you very much.